Thanks, Rajesh, and thanks, Yuli, and all the organizers of the event. It's an honor to speak here today. I'll be talking today about, I'll talk about AI in the afternoon. Today I'm going to be talking about a precision prevention clinic that I run at Stanford for South Asians that we are definitely seeing the benefits of digital health innovation in. I don't know if this is working. There we go. As my disclosures. Okay, so can anyone tell me what two things everyone on this screen has in common with each other? Yeah, Bollywood. That's number one, right? They're all actors and actresses. What's the second thing that they have in common with each other? That's right. All of these people died in 2017 and 2018 from a sudden cardiac event. So if you look at their ages in the lower right inset corner, you can see that only one of them, Om Puri, actually died at an age that we consider to not be young for having a heart attack. Everyone else, less than 65 for women, less than 55 for men, died early from heart disease. So today, our learning objectives are to learn about the epidemic of high coronary disease risk in South Asians, understand the value of testing for non-traditional risk factors in this population, review the challenges and successes of a precision prevention innovation program that I run at Stanford, and review the impact of integrated telemedicine prevention in this clinic on our patient outcomes. So South Asia, just to remind everyone, is this subset of nations here, starting with India, but branching right around there, that we focus on. And what we know is that it's the number one killer. That's not surprising. It's the number one killer most everywhere in the industrialized world. But what you may not have known is that you are 4 times more likely to have a heart attack or stroke if you are South Asian than any other ethnic group. And when you have that heart attack, it'll occur on average 11 years earlier in life. And when you have it, is early, as I mentioned, 60% of those first heart attacks happen early or under the age of 55. But even though you're 11 years younger, you are 40% more likely to die from that heart attack. Yep. Is that better? Great. And traditional risk scores like the Framingham risk score, the pooled cohorts equation, ASCVD, miss roughly about 50 to 80% of heart disease risk in South Asians. So I'm going to start with one of the first patients I saw at Stanford when I started my clinic. He was 44, he's an engineer, he's a little short of breath, he plays cricket, which as many of you, if you play cricket, know is not a very vigorous form of exercise for most people. He occasionally smokes. He currently, back then he didn't have stage 1 hypertension, but he does now, according to that. And his labs weren't that remarkable, right? He's got a little bit of fasting glucose elevation, but everything else was kind of in line. His triglycerides were high. He came to me, and I punched his numbers into the ASCVD risk calculator, and it showed that he had a very low risk over the next 10 years of a heart attack. But if you looked in the fine print, there's a disclaimer. If you're South Asian, this is underestimating your risk. And so it doesn't really help us to use this score. He had an equivocal stress test. He had a very low calcium score, like 10% or something like that. So I ordered a CT angiogram because he didn't want a cath. He had a 99% soft plaque stenosis in his LAD. It was a tiny little bit of calcium here that we found, and he got a stent, and he's doing well. But by traditional evaluation measures, he would never have gotten to this point. He would never have even been started on a statin. So what are we dealing with here? When I looked at his family history, we found that he had a brother who had had a stent, his mother had had 4 stents, and 3 of his maternal uncles had died under the age of 60 from an MI. Okay, so this was the information that isn't in that risk score. There's no evidence of, there's no family history component to the ASCVD risk score. It's now a risk enhancer, which I'll show you in a moment, but his biggest concern was not just himself, his kids as well. So heart disease has risen in India by 34% in the last quarter century, while the rest of the world has seen about a 40% decline in heart attack deaths. And when you look at this disclaimer, what are we supposed to do about it? Well, right now, the most current lipid guidelines, I don't expect all of you to memorize this, for the first time ever includes South Asian ancestry as a risk enhancer, but this still doesn't help with the decision. It says consider a statin if someone might be South Asian and of low or borderline risk. It doesn't really help us in a definitive way. So sometimes I've found it's better to create your own path forward. And like this woman who's found a different way to get where she wants to go without falling down, we needed to figure out a different way to find our path forward without falling down with our care of South Asians. So we started the SATI Clinic, which is the Stanford South Asian Translational Heart Initiative, which is personalized cardiovascular disease prevention for South Asians. And our goals are to do a better job treating South Asian heart disease risk, as well as to develop targeted diagnostic and therapeutic approaches in this population. It's a team-based approach, so there are 4 cardiologists, a metabolic specialist, a few dietitians, a lifestyle interventionalist, and we're doing a lot of clinical research around this in terms of outcomes. So how do we do this? We focus on early risk detection and treatment, and we're looking at both non-traditional and traditional risk. We're looking at every non-diabetic in our clinic gets a 2-hour glucose tolerance test with insulin at 4 time points, and I'll explain why. Probably the only cardiology clinic in the world that does that. We check actionable inflammatory disorders that actually modulate or change our medical management of our patients based on the results. And we have these algorithms that merge these risk factors into risk reduction strategies. So actionable, data-driven, South Asian-specific care pathways is what we are focused on in SATI. We have a great team with tremendous experience around me, so I'm very lucky to have those folks. We have 3 visits over 6 months with a physician, plus 3 to 6 visits with a lifestyle interventionalist. I'll get to what that entails in a moment, with labs at the beginning and labs at the end. Now, when we find and look for these traditional risk factors, we know that they're there. Smoking, hypertension, diabetes, they all make a difference. It's not that they're useless. They're useful. But if you look at the prevalence, really interesting. This is the Coronary Disease Registry in India. This is the Framingham Registry comparing traditional risk factors. Actually, the South Asian population has fewer hypertensive, high cholesterol patients than that Framingham cohort does, and far less obesity, but has a lot more diabetes and a lot higher triglycerides. And I'll explain why in a moment. So just getting back to that diabetes piece, insulin resistance. So steady state plasma glucose is a measurement of insulin resistance. If you are South Asian, this is what your average is. You would have, as a Caucasian person, you would have to weigh 15 kilograms heavier on average to equal the insulin resistance risk of a South Asian. So that's just being that ethnicity, or East Asian, actually raises your risk of insulin resistance dramatically. Why do we care? Well, if you're pre-diabetic, your risk of having a mortality event is somewhere between being a diabetic and being normal. It's not closer to normal. It's kind of right in the middle. And so this is a continuum of risk that if you're not looking for pre-diabetes on the path to diabetes, you are missing a huge pocket of risk for these patients, right? So when we do that in our clinic, if we just looked at fasting glucose, we catch about 18% pre-diabetic. That's actually a lot. But if we do the glucose tolerance testing, we have 50% more, and we uncover diabetes as well. So we're actually capturing a lot of additional risk. Some other inflammatory markers we look for are apoprotein B. Apoprotein B100 is an inflammatory protein associated with the LDL particle. It actually destabilizes plaque and helps atherogenesis. Its counterprotein is ApoA1, which is anti-atherogenic and is associated with the HDL particle. When we check the ratio of these 2 things, we know that they make a difference. The InterHeart study showed us about 10, 12 years ago that if you have a ratio of B to A that's over 0.8, you're in the medium to high risk. Your odds ratio of having a heart attack in this high risk range is 6. That is about 3 times higher than any other known risk factor for heart disease in South Asians. But if you are not South Asian, that same ratio is not an odds ratio of 6, it's like about 2 or 3. So the same exact value for the lab means something different depending on your ethnic or genetic background. And in South Asians, this is it's the most prognostic risk factor known for heart disease in that group. That's why we check it. And so we actually modulate our treatments, and I won't go into all the algorithms, but we may start a statin more aggressively if someone has inflammatory abnormalities than if they don't. And because we know that statins have anti-inflammatory properties, where does that data come from? It comes from the knowledge that we can actually lower apoprotein B with a statin therapy, or we can actually impact CRP levels. So how are we doing as a clinic? So we thought we were doing really well. This is our first 50 patients. We started the clinic in 2014, and we looked at over 6 months how well were we actually doing in reducing body weight? compared to Omada Health, compared to a preventive cardiology clinic that had published their results. We were doing better. We were doing better at reducing heart age by the QRIS-2 heart score. And we were actually lowering diabetes risk really well. We thought we were doing quite well. We had figured out this prevention thing, no big deal. We'll just keep going. So then we looked at the next 200 patients, and we found that from start to end, we were not doing very well at all. We were seeing a lot of patients get better, but we were seeing a lot of patients do worse as well. There's about a 50-50 mix. Not doing worse, but maybe staying the same, and just weren't getting the impact we hoped for. And what we found was that there was an initial early adopter bias in our clinic. It's pretty humbling. We didn't really know what we had done, but it turns out that as we grew, we hadn't grown consistently in our treatment algorithms and our treatment approaches. But also, we were getting people who weren't early adopters, and so we weren't getting that engagement between visits. And so beyond the innovation of the clinic and the algorithms of treatment based off of our risk assessment, we needed to figure out a better way to do prevention, because prevention is really hard. Prevention is not a one-week course of an antibiotic and then you're prevented, right? It's a lifelong, day-to-day, long-term commitment. So one thing that we found was when patients will wait to see you in the waiting room for 30 minutes, 45 minutes if you're really backed up, and that's okay, right? They will wait maybe 2 minutes online on a telemedicine visit. Like, they want to be seen right away if they're online. They won't wait around, which is really interesting, and we'll get to, because they don't like to wait. And I think that this is something that we realized is that when we launched this clinic, this component of our clinic called CardioClick within Sathi about 2 years ago, we've now seen over 600 patients in this, probably close to 700 now. It was because there was a lot of demand. Patients were tech-focused. The average age in our clinic is very young, 42 years old. They wanted to actually have the flexibility to be seen while they were traveling, to be seen at work so they didn't have to lose their parking spot in the parking lot. And so what we have done is we have made telemedicine visits standard for all return patient visits in our clinic. It's an integrated program where they see me twice virtually after the in-person visit initially, and then they see our lifestyle interventionalists 3 to 6 times at different, more frequent intervals to make sure they're following the medical plans and the lifestyle plans that we've instituted for them. And they also do research enrollment virtually as well. Our lifestyle program is a NEST program: Nourish, Exercise, Sleep, and Transcend. And it's really been effective for our patients because they all need these things in various ways. So talking about innovation around prevention and telemedicine, anyone can do telemedicine. Epic has an e-visit option that you can activate through your IT group tomorrow. But if you want to achieve long-term prevention, you have to solve the following risks. You have to be able to solve reimbursement and billing, which is one of the reasons why previous telemedicine clinics at Stanford had failed. We've been able to do that. So we bill at parity to an in-person visit with our telemedicine visits. So that's a very important factor. You have to have technical integration with the EHR, of course, to be able to potentially eventually import sort of aspects of that visit or to show a patient perhaps their own results online on screen. And that's another feature, is if you can get EHR integration with devices and sensors, that enhances your data stream integration, and we're working on those things right now. You have to solve the provider team adoption just as much as you have to do the patient adoption. And that's actually pretty easy on the provider side. My visits are about 10 minutes shorter on average. I finish my note by the time I log off that visit because the patient actually thinks I'm looking at them, but I'm actually typing on the screen right next to them. I actually feel like I'm more engaged in some ways with the patient in that situation rather than looking to my screen and typing while I'm there in the room with them. And you have to have focused team-based clinical goals. I can't emphasize this enough. A one-off telemedicine visit is not going to achieve prevention. You need to have your whole team focused on their medical and clinical goals, and then suddenly everyone on your team can re-emphasize that with the patient every time they visit, and that actually has helped us a lot getting to our goals. And then, of course, because at Stanford we do a lot of research around clinical outcomes, which I'll show you in a moment, that we're publishing right now, and you need to virtualize that process as well. So our research is around operational efficiency, clinical outcomes, care delivery, and health disparities research. Everything is done through their app, their MyHealth app. We basically send them their consent form. We can track every step of the way where they are along their path of the research completion of any given study. and they actually do their consents on their phone. This is something that we've found to be very effective. So what have we seen? Well, traditional in blue, CardioClick, telemedicine in green. These are just lipids and risk scores and weight, but you can see at every single metric is dramatically improving and across the board for CardioClick compared to our traditional, whether it's total cholesterol, LDL, triglyceride reduction, weight reduction, or overall cardiovascular risk reduction, which is a combination of hypertension, body weight, cholesterol, and various other risk factors. So we're really excited by this. We're actually publishing this now. We find that actually 90+% of our patients now are reclassifying their risk from moderate to low or high to moderate with CardioClick, whereas it used to be about 50%. So we've actually had a significant improvement in our risk reduction. Why? Because in our traditional Sathi clinic, only about 30% were coming to see me for the third time, and only seeing the dietitian once over a 6-month period, and actually it was taking them 14 months to complete this whole process anyways. Now with CardioClick, about 75% of patients are coming in for all 3 of their MD visits, and 2.6 RD visits per patient over that same time period. And actually it's a tight 6-month program, and they're actually completing the program within 6 months. So this engagement is dramatic with telemedicine, and I would encourage all of you to explore, even if it's not a prevention clinic, to think about how you can incorporate telemedicine in an effective way in your practices.
1 more minute.
Yep. So Sathi risk reductions, just to summarize, effective cardiovascular risk reduction in South Asians. So we started with an innovation in how we looked at risk. So we looked at non-traditional and traditional and developed algorithms to help guide our management. We also found that non-responders needed higher touch solutions. And this was found to be a problem when we weren't seeing improvements across the board. Insulin resistance, prediabetes epidemic is really, we think, driving higher cardiovascular risk, and I can talk more about that if you're interested afterwards. But CardioClick has really helped us with operational efficiency, treatment efficacy, really positive feedback from the patients, and now we're adding wearable and home sensor devices, and we're studying the impact of those and expanding to other departments within cardiovascular health at Stanford. But I really have to emphasize a coordinated team-based effort. Thank you.